Stuck inside my mind in this quarantine house. The light at the end of the tunnel isn't inside. Where do I go to find someone to talk to about all of my wants? You can never validate me, tell me the lies. I searched until nothing there and missed online. But I'm anxious and depressed and my coping skills are not fine. We were to fit and it felt like a waste of time. I heard an interview and I felt an instant connection. I learned CAT, DVD, and my book skills and each and every session. I'm going through, ready to ask the next question. The next question. The next question. The next question. The next question.
If you enjoyed this episode, please consider making a donation to the podcast via Venmo to the username @NQCATX. Hello and welcome to NextQuest podcast, where I ask your potential therapist questions so you don't have to. I am your host, Noah S. Garcia, licensed professional counselor supervisor. Today, I welcome to the show Sydney Kudeviz, licensed master social worker, who will be discussing her area of specialty, demystifying the response and treatment of child abuse. Welcome to the show, Sydney.
Thanks for having me.
So tell us, what are your credentials and experience?
So I am like you said, an LMSW. I've been a social worker close to 5 years in Texas.
Very cool. Where did you go to school?
Texas State.
Nice. Mm-hmm. So seeing as though you're a social worker, I thought it would be, you may be a good person to ask this question. So my understanding is that there are 3 different types of licensure one can obtain as a social worker. Those would be like, is it an LBSW or a BSW?
Yeah, I think it's a BSW.
And then LMSW and LCSW. Can you talk to us a little bit about the differences and requirements in education between these? And what about the differences in the types of employment opportunities in each of these different licenses?
Sure. So to be a bachelor social worker, you have to have an undergraduate degree, I believe, in social work. And then you take an exam and you pass the BSW exam. And that basically, it's sort of like certified that you have done social work courses, but you're not a fully licensed social worker. I kind of skipped that process. So my undergraduate degree is actually in political science. And so I went right to grad school. And so I have my LMSW, meaning I completed a 2-year graduate degree program in social work and sat for the board licensing exam. And so then the next level is an LCSW, licensed clinical social worker. And so to be one of those, you have to complete a certain amount of clinical hours under supervision of an LCSW supervisor, and then sit for a second exam. So I am in the process of working on my hours. I have a good chunk done. So I have about 4 or 5 months until I complete my clinical, and I think it's 360 hours. Don't quote me on that, but it's a certain amount of clinical hours you have to have. It takes about 2 years. If you work full time, it should be a 2-year process. And so only certain positions, the more clinical type positions, because as a social worker, you can do such a variety of things. You can do case management, you can be a school counselor, you can be an individual therapist. And so certain kinds of positions count for clinical work. And so the social work board has to approve that.
Gotcha. What about the differences in the types of employment opportunities?
Yeah, so LCSWs, they are able, so both LMSWs and LCSWs can work in hospitals. They can work for victim services. They can work at schools. As an LCSW, you're able to take insurance, and so that's the biggest difference. As a BSW, it's very different because you're not a fully licensed social worker at all. So, and I never was that, so I don't know exactly where a lot of BSWs fall in terms of employment. But
I've seen a lot of BSWs in like nonprofits.
Yeah, exactly. I think, and that's sort of like, I think like a good segue, before they go back to LMSW. But so LMSWs and LCSWs can both see clients privately, things like that, but only LCSW can take insurance.
Right.
And usually they're more, have more experience in the one-on-one private counseling. They may work more like mental health hospitals, things like that, be sort of higher up in the counseling field.
Got it. Okay. So now my understanding is that you work at a hospital, and at this hospital, there are various teams that you work on. Can you tell us more about this?
Yeah. So I work on one specific team, but so how a hospital works in terms of social work there, and this is how most hospitals in my experience work, particularly the one I work at, there are floor social workers. And so they're the ones who work with patients admitted to the floor. They make sure they have everything they need in terms of understanding medications, understanding the diagnosis, if they have other housing needs, transportation, things like that, provide them with support. There's also specialty social workers who maybe work in the emergency department or who work with children with cancer, things like that. My sort of specialty niche is I'm a part of a consult service in the hospital that is a child abuse specific team. And so everybody on my team, we work in the child abuse field.
Okay. So is being a social worker your first career?
It is. So I was an undergrad political science major. Thought I wanted to do poli-sci, work on like campaigns, that kind of stuff. I'm from the DC area. And so I went to school, undergrad and degree at American University. Quickly realized I wanted to help on a different level, that campaigns were a little too macro for me. I like sort of the micro in terms of helping. And so I graduated with my undergrad in poli-sci, moved to Texas, kind of spent a year just working, doing a couple different things, figuring out, I thought I wanted to do social work, but there's also, obviously you can get your LPC or there's other ways to get to the counseling avenue. So just kind of figuring out which one was right for me. But yes, I would say this is my first, professional career.
What drew you to being a social worker? And did you always know you wanted to be like in a hospital setting, for example?
Yeah, actually, so working in the child abuse field, that's something I never really thought about at all. I was really lucky and able to intern at the Travis County Child Advocacy Center, just kind of almost a random internship I had. I interned at communities and schools. I really thought I knew I wanted to work with children. That's sort of my passion. Children and teens. And so I thought I would be like a school counselor, a school social worker, or do individual counseling. Had this opportunity at the Center for Child Protection, and I really loved it. And so that kind of is what got me into child abuse specifically. In terms of social work, no, I didn't always know I wanted to do that. I pretty quickly figured out in undergrad that I wanted to do something psychology related. But it just sort of social work made the most sense. And I'm glad that I chose this path.
Cool. Well, tell us a little bit about yourself, hobbies, interests, TV shows you're watching, music, pets, etc.
Yeah, I'm a big reader. Unfortunately, during the pandemic, I think my reading has lessened, unfortunately, but definitely a big TV watcher. TV, movies, board games. I have a dog, Redford, who is a Pomeranian. He's a rescue. He's the love of my life. He's probably about 8 years old. I've had him for about 4 years. Yeah, just kind of exploring all that Austin has to offer. Love watering holes, Barton Springs, all that kind of stuff.
When there's water.
Yeah, exactly. When there's water. Yeah, that's true. Very true.
It's always a bummer when you go down there, and it's like, May or June, and there's just nothing. That happened to me once. It sucks because you're expecting water and then it's nothing but bone dry.
Yeah, I'll even take a pool. That's fine. Just put me by a body of water. I'm very happy. But yeah, happy to be having hopefully a little bit more of a normal summer again.
Yeah. Especially now with the new CDC recommendation about masks, huh? Okay, well, in talking about child abuse, just so we're all on the same page, can you define what child abuse is and the various types of abuse that may occur?
Yeah, so I actually I pulled up the Texas code. I can talk about it just from my own experience, but I can also add that as well. So child abuse can include multiple different kinds. There's physical abuse, sexual abuse, neglect, medical abuse, emotional abuse, all those different kinds of things. The way it's defined here in Texas is mental or emotional injury to a child that results in an observable and material impairment in the child's growth, development, or psychological functioning, causing or permitting the child to be in a situation in which the child sustains a mental or emotional injury that results in impairment. So physical injury is covered, failure, and it also covers failure to make a reasonable effort to prevent any of those things.
Mm-hmm.
It also talks about sexual misconduct with the child, human trafficking, child pornography, things like that.
Okay.
All those are covered in kind of the child abuse field, I would say.
Mm-hmm. Now, just also to make things a little more clear, child abuse can happen in one instant or across a period of time, right? I just want to make sure that's clear.
Yeah. Yes. From what I'm understanding, you're saying you're saying like one situation that may happen, or it can be happen.
Prolonged.
Yeah, exactly. Absolutely. It can be one situation where a child is caught in domestic violence situation, or it can be continuous child abuse. I'm not an expert on the criminal side, but I'm a little bit familiar. And there's even like a definition for a higher penalty of continuous sexual abuse of a child. So yes, there's continuous, and then there's sort of like a one-off situation.
And something that I don't think a lot of people realize is that in domestic violence situations, say, we'll just use a cishet couple example here. Say a woman is holding her child, mm-hmm. and the man hits her or pushes her, mm-hmm. that would also fall under child abuse.
Absolutely. Yeah. 100%. Witnessing violence, mm-hmm. or witnessing domestic violence is its own thing, but also potential injury that can happen during a violent situation. Absolutely.
Okay. So what specific signs can medical and mental healthcare professionals, neighbors, friends, family, etc., look out for that could indicate that child abuse is potentially occurring?
Yeah. So child abuse is tricky because kids, outcrying, we call it an outcry when they make a statement of abuse happening to them. It is hard for kids to outcry, and it often does not happen in the moment. It happens weeks, months, years later. Someone explained to me once, that's one of my favorite things I use in talking to parents, is for a child outcrying about abuse is like jumping off a cliff and hoping that there's a net at the bottom to catch them. They have no idea. So
a lot of fear.
And so a lot of times that stuff does come out in behaviors, and it's hard because these behaviors that I'm going to list, they could be from other things as well.
Right.
Aggression, complaining of stomach aches, isolation, so, all this kind of stuff that, like I said, any sign of, hey, something's kind of funky, it could be something as normal as, parents are getting divorced and kiddo is going through something, or it could be abuse, aggression, sexually acting out,
Hoarding food.
Say it again.
Hoarding food.
Hoarding. Yeah, exactly. Any sort of maladaptive behaviors can be a sign. I think the list is so big, it's hard to go through.
Right.
But it's definitely, a lot of it is there. And it's with kids, I think a lot of it is like hindsight is 2020. When I talk to parents, I go through and say, what are some, do you have any behavior concerns with kiddos? And they go, well, now I realize that they come home and shut themselves in their room. And I thought they were just being a teenager, or they complain of constant stomach aches, nightmares, trouble falling asleep, having a reversal in bedwetting. Those are all things that can be signs. Anxiety. Yeah. Is an anxiety happening because a kiddo is starting a new school grade or because there's something happening? So it's hard to use signs only, but they are important to look out for.
Absolutely. And of course, that's beyond any sorts of physical indications like unexplainable bruises, all those sorts of things.
Yeah. And we can talk about the physical stuff too, because a lot of times it's not easy just to go by injuries alone. Bruises.
Because kids are kids.
Kids are kids, bruises fade. You have to know specific indications. And I can talk about that too. Locations on the body where if you see them, that you should be concerned based on the age. But kids hide, I've seen parents who tell kids to wear long sleeves to school, things like that.
Mm-hmm. What other sorts of physical indications and like places might there be bruising?
Yeah. So things that give really big alarm bells to us in this field are bruising on the ear or behind the ear. It's actually really hard to bruise the ear. It's kind of a soft, foldable area that if it gets hit, it'll kind of bend with whatever is being hit with it. So if there's bruises behind the ear, that can be pulling, boxing, yanking. And it all depends on the age of the child, right? A child who is a baby and doesn't walk shouldn't have bruises, right? Without a history. Things happen, right? Kids fall, they drop, they roll over, like that's 100% normal. But a child who is not able to walk should have a history of why there are injuries on them. Bruises to the shin are totally normal. That's a normal part of a child who is able to walk, run around. But injuries, on the face without, an explanation behind them, on the torso, things like that. The ears are the biggest ones because it's very rare. It's really hard to get an injury behind the ear, in the ear without, having a really clear explanation of what happened. That's a big indicator. But kids are kids, that doesn't mean just because a kid has a bruise or anything like that. Also, you cannot date bruises. That's kind of a big myth too, is, we think you look at a bruise and, oh, it's kind of like greenish or yellow. It must be old. But everybody bruises differently. Mm-hmm. And so there's no way to look at a bruise and say that's 3 days old or something happened 4 days ago, or that's not that deep. All a bruise shows is that injury happened, but some people may not bruise at all, or some people may get really deep purple bruises. Some might not even get to that purple stage. They just get to a light yellow, so, bruises tell you something happened, but not when it happened.
And, I think another misconception that I'd like to mention is that, most people assume that child abuse can just occur from an adult to a child. Mm-hmm. Now there's child on child abuse.
Absolutely. The most common I would see is child on child sexual abuse. That does happen fairly often, or sexual assault, all those kinds of things. The age difference does matter. Mm-hmm. And it also matters in terms of the criminal code as well. But yeah, absolutely. Anyone can be a perpetrator.
Mm-hmm. I mean, even siblings, if an older mm-hmm. sibling is beating up on their younger sibling, mm-hmm. that could be considered child abuse.
Mm-hmm. Mm-hmm. Yeah, that's something that definitely, and I think it depends like how far you would escalate it. Like if there's a family dynamic thing going on, it's clearly mm-hmm. counseling that needs to get involved, so things like that. But absolutely, yeah, child abuse can happen in so many different kinds of situations.
So can you tell me more about, you had mentioned it depends on the age, like between the children, and
Sure.
that as far as like criminal penalties and the like. Do you happen to know a little more about that?
Yeah. So the age of criminal responsibility is, forgive me, it's 12, I believe. I think 10 is the youngest they would ever look at any sort of like criminal thing happening. Don't quote me on that because now I'm forgetting if it's 10 or 12, but there's a very specific age where anything younger than that, law enforcement would never even get involved. There's also, in terms of sexual abuse, there's, in the state of Texas, there's like an age difference, in terms of what is when you're able to consent to sex and when you're not. I have to look up the exact numbers because now they're getting out of my head. But, so age and cognitive level does make a difference, right? So even if the children are of the same age, right? Say there's sexual abuse concerns between two 13-year-olds, maybe, but one is in special education or has a different cognitive ability, that's something you would look at as well.
I'm looking at something that says, well, the age of consent in Texas is 17.
Yeah, it's I think it's kind of funky. I think it's actually younger than that. I'm looking it up too. So it's technically 14.
14. Yeah.
So
but the age differential of 3 years.
Yeah, and so within 3 years of 14, yes. And so anything below 14, like even if it's two 12-year-olds, they cannot consent to sexual activity with each other.
Okay, got it. So we know that medical and mental health care professionals, as well as others, such as like teachers, are considered to be mandatory reporters and are required to report suspected child abuse within 48 hours of becoming aware that something is going on. When a professional makes a report, who do they report this to?
Yeah. And so I wanted to talk about the mandated reporting because actually in the state of Texas, everybody is a mandated reporter, really? Whether you are a professional or not. It's in the penal code. Now, it's specified that professionals have kind of a certain like extra responsibility.
And penalties.
Yeah. And so I'm going to go ahead and read that. So it says a professional means an individual who is licensed or certified by the state or is an employee of a facility licensed, certified, or operated by the state, and who, in the normal course of official duty or duties or license or certification, is required and has direct contact with children. This can include teachers, nurses, doctors, daycare workers, employees of a clinic, healthcare, reproductive services, juvenile services, correctional officers, things like that. But technically, it does say anyone who has a suspicion is required to make a report. And so it does say that the professional shall not make a report later than 48 hours and cannot have someone else make the report for them, which is a big one that comes up. And so what happens, I'll kind of walk through the steps of what happens when you make a report. My advice, make a report as soon as possible, try not to wait. And so there's two ways you can go. You can call the Texas Abuse Hotline, which is really an easy number. You just Google it. Or you can make a report online. A report online, I would say only use that if it's something really non-urgent. But I would say go ahead and call. You're going to probably have to wait 20, 30 minutes. That's just part of it. I've waited upwards of 60 minutes. I've made probably hundreds of CPS reports, maybe not quite that much, but a lot in my 4 years, more in this field. And so you make a report to a screener. And so that is their only job, is to screen cases. And they're looking to see, does it raise to the mandated legal requirements? And so they're going to ask you questions about the home, what the concern is. And so CPS only investigates concerns that are inside the home or like within a home life or a school or like, so there's CPS and there's also CCL, child care licensing, and they're kind of all part of under the same umbrella. And so if you have a concern about someone at a daycare, they would go to them. But Child Protective Services, and there's actually a specific term for, they're actually Child Protective Investigators. That the name has changed in the state of Texas, but I'm going to say just CPS because it's a term we all kind of understand and know what that means. And so when they are screening, they're trying to figure out, is there a concern for any of these abuses, physical abuse, sexual abuse, neglect, medical abuse, human trafficking, things like that. If it does raise to that level, they will then send it off to be investigated. And so they will send it to a router who assigns it to a unit. So when you make a call, you're talking to a screener. And they have mandated questions they have to ask. But really, when you talk to them, I always tell people, make it clear, understand where, explain where the concern is coming from, if it's in the home, outside the home, things like that.
Mm-hmm. And when we make a report, we also have to have information it's helpful if you have names, dates of birth, addresses, phone numbers.
I tell people not to get caught up in that because I think sometimes it can be oh my gosh, I have to have all this information.
Right.
You just have the minimal child's name and date of birth, or the caregiver's name. Don't get too caught up. Because I think that can be sort of an anxiety producing thing of they're going to ask me all these questions. I don't know the answers.
They'll take whatever information you have to give.
Just say don't have it, or just say don't have any of this info. Here's what I have, and that's totally fine.
Mm-hmm. Okay. So if a family member, friend, neighbor, etc., suspects child abuse is occurring in a home, why should they and who should they report this to? And I think a big question that people have is are they able to make a report anonymously?
Absolutely, you can make a report anonymously. And so I do, since we are talking about CPS and these systems, I do want to also talk about the fact that with CPS, there are lots of concerns of white supremacy, issues of racism, all those kind of stuff. And so I want to definitely name it. And that's a whole podcast we could talk about separate. And so those concerns, concerns of economic status when making a report, all those things are very valid. And so I just want to also say that research shows child abuse happens equally across race lines and socioeconomic status. So child abuse happens equally amongst all different groups. There is an imbalance of where it's reported.
Right.
And so people of color, families of color, it is reported more than with white families, white upper class families. So there's an issue in reporting, but abuse happens the same amount of those households. So just wanted to say that because that can also be a concern of why people don't report, right?
Right.
And so concerned about what's going to happen, right? Are families going to get split up, all this stuff. But always, if you have a concern, make a report. And here's why. I've made enough reports to, if it's not something they can investigate or don't have a concern, they will just close it. It will not move further. They are so busy. They are not trying to add any more cases than they have to their caseload. And that's another thing too. I've worked with a lot of investigators, CPS investigators, and they are overworked, underpaid.
Oh, so much so.
I could never do, I support them a lot. So a lot of what I do is getting them information they need and working with them, making sure they understand what's going on from our end and the medical side, but I could never do their job. They do amazing work for, people who never want to have to hear from them or talk to them. But what I tell people is if you have a concern about, neighbor, family, friend, something like that, that piece may be the piece of the puzzle that CPS needed to solidify their concern. Because this is what happens a lot, right? They get a lot of reports of kind of vague concerns, they investigate, but there's not enough to really make a determination. But what you see or have a concern of can be that last piece of the puzzle. And that child is depending on you. Those children are depending on you to make a report and help them if there is a concern of abuse. Like I said, things go through lots of different cases and reports go through lots of different people before it even gets to be assigned. There's lots of people that are part of these cases. So you only see one little piece of what's going on, but there could be a whole world of, trauma you're not seeing.
Right. So once CPS, or which falls under the Texas Department of Family and Protective Services, receives a report, what happens from there?
They receive a report. If it gets approved to go through, there's enough concern, something that's happening in the home, it goes to a unit, and then it goes to a worker. And it all depends on what, there's lots of what type of abuse they're concerned about, right? So there's like different levels, there's like priorities of cases. So if they're concerned that there is sexual abuse going on in that home with a caregiver, father, aunt, uncle who lives in the home, they're going to investigate it. As like they have a certain hour requirement they need to meet. So cases get sorted into these different priority levels. And so based on the priority level determines when they will go out and make contact with the family and start the investigation process. So for example, if we make a report on physical abuse and that child is admitted to the hospital, okay, they have a safe place to be that night, then they come out the next morning. But definitely things like sexual abuse, they're going to act immediately. Those are, high priority cases.
Which leads me to our next question, which is, in your experience, what sorts of cases generally require that the child be immediately removed from the guardian's care? Are these children placed with family, if appropriate and available, or are they put into a children's home or the foster care system?
So, and I'm going to talk, since I've never been a part of CPS, but I have a lot of familiarity. I'm going to talk to it as best as I can. First off, it is part of their code that if a child is removed, they have to look at family members first. So the caregivers, legal caregivers of that child, are able to give them a list of people and say, here's all the family that this child can go with. So they always start with family. That's like required. Family or family friends. So the parent caregivers are able to provide a list of people, where the child can go. Now CPS has to check them out, right? Do they have a CPS record? These people themselves, right. They have a criminal record. Do they meet the CPS requirements of being a caregiver? So a child would only go to foster care if there's no other family who can take them, or those family members don't meet CPS's standards. Maybe they have a criminal history or things like that. But also it's important to know that CPS cannot just take children. I think there's a lot of misconception of that. Things have to get improved by a judge. Not saying that system is perfect either, but there's this idea that they can just take children. Definitely is not true. More often, I feel like, in my opinion, sometimes I've seen, man, I wish this child was removed. I have high concern about these caregivers, and the judge didn't approve it. So foster care is and should be a last resort. And so things happen quickly, and so parents also have some say, right? So in a sexual abuse case, say a child makes an outcry that father sexually abused them. If they agree to a safety plan where that father leaves the home, they're not going to take that child, right? If mom is being protective. So it's really about protectiveness. That's the biggest thing they're looking for. How protective are these caregivers? If a child makes an outcry of sexual abuse by somebody in that home, are the parents able to say, okay, that person has left the home, or we're leaving the home. So, okay, you're not going to, take that child. But, in physical abuse cases, a lot of the times, a lot of cases I work with are younger babies and children who can't make an outcry, when that's really hard, because we look at injuries and say, hey, this child has X amount of rib fractures, and, we're not sure who did this. That eliminates all those people who may have potential contact with that child. So it really just depends. But if caregivers are willing to be protective, CPS wants to work with them, is not just going to take the child.
Right. I mean, it's our responsibility to protect children. Any which way you look at it, no matter who you are.
Absolutely.
So what sorts of cases, just giving us a little more insight here, would require the immediate removal? Like, I know you said like they're looking for protectiveness there, but would that include like sexual abuse, if
Sexual
those
abuse.
sorts of things?
Sexual abuse, if the perpetrator, so a lot of the times with sexual abuse cases, when they make an outcry, they usually make an outcry about a specific perpetrator. So if that person refuses to leave the home, or another caregiver refuses to take them outside the home, that would probably be a removal.
Gotcha.
If there's a child injured and they don't know who could have caused these injuries, that would be a removal. Most likely, like I said, I'm not part of CPS, so I'm just speaking to my experience of working with them. But cases where they don't know who the perpetrator is and there are injuries, or sexual abuse, if there's not a way for that, if that caregiver is unwilling or can't leave that home. But usually they put in what they call a safety plan. And so a safety plan is something that the caregivers sign and agree to. And if they breach that safety plan, that could possibly be a removal. But safety plans, if a child makes an outcry that grandpa or uncle or someone, because most sexual abuse cases are someone they know. I've been doing this for like 4 years, and I can count on my hand the number of sexual abuse cases that are a random stranger. So it's unfortunately, it's going to be a relative or family friend, someone they know. Both parents agree that this child will not have any contact with that person. Okay, that's fine, so it really just depends. But yeah, anything immediate, sexual abuse always, as soon as possible, that child needs to be away from that person.
Okay. Now, I know that often when abuse is suspected in the home, CPS will require the guardians to undergo things like parenting classes, mandated counseling, substance abuse treatment, domestic violence classes, and even drug testing, for example. In your experience, would you say that a large percentage of parents or guardians are able to maintain custody of their children long term? Or do you find that most children who are being abused wind up in the foster care system?
Yeah, so it's hard because I don't always see cases all the way to the end. I'm there in the first part of what's happening. But from my experience, yes. I mean, a perpetrator of sexual abuse should never have custody of that child again. So that's one thing. But, there's things like excessive discipline or neglect or drug use in the home. Yes, CPS is actually, and that's something too, when I talk to families who have a CPS investigator involved, CPS actually is a really good resource. And I try
they're such a good resource.
Yeah. And so, because of TV and many valid experiences and whatnot, it's just seen as this like nuisance or this, and I fully understand that. But for families in need, they actually can provide a lot. Like I said, they absolutely provide parenting classes. They help parents get involved into rehab. They're able to provide supplies. If say a family doesn't have a car seat, someone makes a CPS report because a child is being transported without a car seat. That's a totally valid report, right? That's really dangerous. But from my experience, what I have seen, no CPS worker would just take that child. They would get them a car seat and make sure they knew how to use it and close their case. I've seen that happen a fair amount of time, get child into daycare, things like that. So they're actually really helpful and have a lot of resources. And that's actually what they're passionate about. But unfortunately, understandably, it's not always seen that way. But yes, I do see that happen a lot. A lot of times kids are only in foster care temporarily until that parent can work services. And services I've seen, healthy discipline, understanding developmental needs of a child. So really helpful stuff.
Yeah, no, I agree. I think that, there's been some times when I wouldn't say made a report, but rather like made a referral to CPS, because somebody needed resources and they were able to help them out with all sorts of different things. So
if they need clothes, or sometimes they sometimes know more about like how to get like an energy stipend or some of the like things I actually don't know. More case mentee, they actually know more about that. So they can actually be a really good tool. And I have seen that relationship go well where a caregiver has actually been really thankful for a CPS worker. Like I said, I don't want to just paint paint them in this, rosy light, because they're just
Right.
like anytime you work with people, there are people who are better at their job than others. You know what I mean?
Yes.
So, but part of the problem too is there also is a really high turnover rate because
Yes.
it's such a hard job. So
Burnout.
it's just awful. And so, a lot of people are thrown in and they're having to learn, trial by fire. It's a very challenging position. And so there are definitely a lot of problems. They need more funding.
Not only that, but it's kind of a dangerous job. You're going to people's homes.
Oh, it's so dangerous. I've seen, and part of the screening process when you make a CPS report, they ask you, like, do you know if there's guns in the home or gang involvement? Because it is a really dangerous job.
Or dogs.
Yeah, right. And there's part of the law, their CPS mandate says they have to have eyes on the child. If it meets a certain criteria, they have to have eyes on the child within a certain amount of hours, right? So they have to just sometimes go to that home. Like I said, I'm always so thankful for CPS. I've worked with them for years. I could not do that job, but I have so much respect for them.
Same. It would break my heart, and I know myself, and I would just burn out really quickly.
And they see terrible stuff too. I mean, we see a lot of, you're in the child abuse field, you're going to see a lot of trauma. But they having to go to the house and stuff, I just think it's a different level of trauma. And they have more cases than I see. So they're just constantly working with high trauma, things that if you're not in this field, you don't understand are happening every day, things like that. I mean,
right. That alone has the potential to warp your view of the world if you're not careful.
It does. And it does, right? It absolutely does. So I'm very big advocate of, like, we need to take care of our CPS workers. We need to make sure they have access to therapeutic services. They have self-care for themselves. I think there's not a lot of that. That's actually something I'm really passionate about, is like, we need to acknowledge what they go through. And so I try really hard to support them on cases that we work together. I ask them, hey, how are you doing? just sort of be there for them to talk to, because also they just have so many. There's no time to, like, I think, for them to sit and, like, process what they're seeing, So I try to help when I can.
Yeah. So what happens when a child who has been in the foster care system ages out? I know this maybe be kind of like beyond, the work that you do, but, what sources are available to help these very young adults?
Yeah, so I don't know a ton about that. So I'm going to just talk about what I do know. There are lots of programs to help that shift, or from aging out of the system, they say.
LifeWorks.
They have stipends, I know, for college. They have living stipends. I believe they get free childcare for a certain age. So there's a lot of stuff they do get. I know there's things that help them, like, pay for school books or just different programs. So, that's just a really rough thing to go through. Like I said, a lot of the kids I work with are so young, and I don't always see these cases through to the end. So I don't know. I don't have a ton of experience with that. I do know there are a lot of programs to help support kiddos there. There could always be more, but there definitely is a lot of transitional living stuff. I know there's, like, programs to help them learn how to, like, manage money and all this kind of stuff.
Yeah. LifeWorks is the one I can think of off the top of my head.
Yeah, they're great. But yeah, definitely, like, through the state, they have, like, a free tuition system. So
that's awesome.
I think part of it too is making sure they know what they have. I don't always know that they know what they have access to.
Right.
So I think that sometimes that's part of the issue, is actually all these different things they're, like, able to have, like, fees waived for and stuff like that, like some housing stuff, but just not having access to that, I think, is the challenge, knowing where to ask, or that you're able to do that.
So since you work in a medical hospital, I would imagine that from time to time you see a case of, like, Munchausen by proxy. For people who don't know what this is, can you talk about what it is, why it's concerning, how a medical or mental health care professional can spot this, and what the general response following a report looks like?
Yeah. So we actually use the term medical child abuse, but Munchausen by proxy is what most people know it as. But just so you know, I'm going to refer to it as medical child abuse because that is the official name of it. And so Munchausen by proxy is the intentional. It is using the medical system, typically for attention or for some sort of benefit that a child does not need. So that can be medications given to a child, medical appointments, surgeries, a variety of things using the medical system that is unneeded for a child. And so I'm going to look up the exact definition because I think it'll be really helpful. So it refers to a child receiving unnecessary or even harmful care as a result of a parent or caregiver exaggerating symptoms, fabricating symptoms, physical findings, or intentionally inducing an illness in the child. So medical child abuse is really hard to diagnose and sort out because most of the cases, the child actually does have an element of illness from what I've seen. This is all just from what I have seen in my experience. It does come up, it does happen. But usually how it starts out is it's not like a completely healthy child and, parents start doing something nefarious. It's usually a child who has some element of illness, like a seizure disorder or developmental delay. But parents will start fabricating extra symptoms or fabricating needs or fabricating sort of like what the child can do or their developmental level. And usually that looks like fractured care. So it'll look like parents taking their children to multiple different hospitals, multiple doctors. So that's why it's so hard to diagnose because, by the time someone gets, oh, this is concerning. Hey, mom keeps saying that the child stops breathing at home. We've never seen that, but she keeps taking him to the hospital. They've already moved on to another hospital. So investigating a medical child abuse case takes years. And it's really, really challenging. Sometimes it looks like parents making reports, like intentionally making multiple sexual abuse concern reports. And so kids going through different exams or things like that. So it can look like that. The main thing is sort of this idea of a child already having some sort of illness and a parent taking advantage of that and fabricating, exaggerating symptoms. And so really what it looks like in the investigation process is going through piles and piles of documents. And so if there's a concern of that, always make a report to CPS. And so usually they will consult a child abuse team, medical team. And it takes a lot of collaboration of getting medical records from multiple hospitals, multiple states, they move between states. And a lot of the times the caregiver may be in the medical field themselves. And so they know what to say or have access to drugs or have access or know the right, like mostly it's, knowing the right thing to say. So it does happen. It probably happens more than we know because it's so hard to diagnose. And also children have real ailments, and you don't want to assume that someone is making something up, but there are different things, after going through lots of documents, you can have an inkling, but it's actually a very hard thing to prove.
I can see why. And there's an element of like doctor shopping there in some ways.
Yeah, there is too. And that's sometimes too, what's hard is it's like, well, just because someone goes to different doctors, it's important to advocate for like your needs and find the right doctor. And I do think a lot of times pain isn't believed. And, so I do believe all that, but there's usually other stuff happening. There may be like mental illness in the caregiver, there's some other maybe like psychosocial red flags happening.
For sure.
That kind of maybe we just need to look into this more and see, okay, it's, looks like they've lived in multiple states and have had, or multiple diagnoses, and then parents don't refill that prescription, but they say the prescription's not working. So it's like all this, like looking at like really chronologically, step by step. Okay, they were diagnosed with this. This is what they said. This is what the parents reporting. Is there any evidence of that? Things like that.
Mm-hmm. Mm-hmm. So really, I mean, it ends up in an overutilization of medical services.
Absolutely. It's over utilization, and it's considered child abuse because it's a child having to go through tests or medications or things that they do not need. So it's a over medicalization of the child. But
and it's to meet the need of the caregiver, really.
Yeah, it's for the caregiver is getting, it's so complex what they get out of it, right? A lot of times caregivers who engage in medical child abuse, they may have their own trauma history. They may have their own history of physical abuse, sexual abuse, neglect. They may have their own. So yes, a lot of the times it is meeting some kind of need, and it's absolutely for the caregiver, for the benefit of the caregiver.
It's something we would call like a secondary gain, right?
Mm-hmm, mm-hmm. Yeah, and it's so hard because it's like, what are they gaining? They're gaining attention, or they're gaining
sympathy,
right? Right. The sympathy piece. So if you have your own trauma and that trauma hasn't been resolved or recognized or seen, yeah, absolutely.
So one movie that comes to mind about this, about medical child abuse, that I saw fairly recently is called Mommy, Dead, and Dearest. I think it's streaming through HBO right now.
Yes, it is.
A few questions. Mm-hmm. Have you seen it? Or do you generally stay away from like work-related things outside of working hours? If you have seen it, what are your thoughts on it?
Yeah. So yeah, Mommy, Dead, and Dearest was, I think, one of the bigger medical child abuse cases that really was like, because they're so interesting, right? Like, I mean, that documentary is fascinating.
Yes.
And that stuff is, because it's so interesting, because it's so complex and
so many layers.
Away with it for so many years, but then when it unravels, it like, for one is, and they're not all as extreme as that. That one was very extreme. Just like, anytime like a documentary or something is made, it's like the most extreme of the cases because that's the most interesting. And when it unravels, I mean, they unravel hard, just like that one did. So yeah, I think it's really interesting. And definitely after that came out, and after the Hulu TV show of it came out, the TV show of the documentary, I had a lot of people asking me questions about Munchausen's by proxy, medical child abuse. And so it doesn't usually happen like that. That's a very, rare way that kind of went down. But it's just fascinating look at the psychological, state of the mom, the child. In terms of what I watch, I'm more picky because I want to avoid secondary trauma is a real thing. Part of my work is I'm engaged in vicarious trauma, all day, essentially.
Yeah.
So I am picky about what I watch. And I've also been doing this for so long. I know the level of what I can take and what I can't. When I first started working in child abuse, I was stricter about like, I don't really want to watch anything like Law and Order SVU or stuff like that. Now I can watch that stuff and it's fine. The ones that are really interesting, I definitely want to watch, because also it's like part of my field, it's kind of, especially if it's a documentary, it's, somewhat educational in the field, and that's such a big case. And, people talk about that a lot. So I think it really depends on what the content is. Certain things I really do. Like I said, Law and Order SVU, is also the one when I tell people what I work in, they bring up. And I did take a break of watching that because I just didn't need to hear more sexual abuse stories, on my free time. But Benson's amazing. So, got pulled back in. Yeah, I would say I'm picky. But I have a clear sense of when I need to step away from some sort of media.
Okay. And for our listeners who haven't seen Mommy, Dead, and Dearest, it's basically the story of Gypsy Rose Blanchard, who, together with her boyfriend, murdered her mother, and Gypsy had suffered medical child abuse at the hands of her mother for many, many years. I believe she was even that the mother even said that Gypsy was unable to walk
Yeah.
And she even had an unnecessary feeding tube.
Mm-hmm. A lot that happens a lot. Yeah, things like feeding tube. So that's a big one too. I think that comes up in medical child abuse cases, is parents saying the child needs a feeding tube because they can't swallow, but then when they end up kind of testing it, it's, oh, this kid is able to take food down. So yeah, that comes up a lot. Yeah, it's just a very fascinating case, and I believe the mom, Dee Dee, she was like a nurse's assistant or something.
Mm-hmm.
She worked somewhere, she was something in the medical field. So she had this sort of like cursory knowledge of medical stuff. So she kind of knew
what to say,
what doctors might have red flags about, or what medication she could give. I think she gave, some of the like medications Gypsy thought she was taking were actually things making her have symptoms. Right. So,
right.
Dee Dee had access to some of that stuff. So there's usually not always, but I think there is some sort of element of like access to the medical profession or knowledge of, even if it's just kind of like on the periphery.
Mm-hmm. So fascinating.
Yeah, very interesting. I feel like there was another one that was a big deal recently. Now I can't remember.
Yeah, no, I have one. I was thinking about it as we were talking, and there's another one that's popping up in my head, but I can't put my finger on it.
The Mommy Dead and Dearest is like the biggest one that I think people know of. But there are a couple other really interesting ones, a couple of good podcasts, I think, that cover those cases.
Yeah, I'm a huge true crime buff. I love all that stuff. One of my bachelor's degrees was in criminal justice, and nice. I did it really just as a hobby. That way I could take like forensics classes and stuff, and it was fun.
Yeah, I'm a big true crime person too. And that's what a lot of times when I say I like am picky and choosy about what media I listen to, I did have to take a break from like the true crime podcasts and stuff, because I was like, man, I'm just like entrenching myself in trauma constantly. That's probably not a good idea. So I did take my own break, but I love it so much. And I'm kind of back into listening to them, and I feel good about it.
That's good. So, therapy is a must for survivors of child abuse. What percentage of these survivors would you say actually wind up linked with mental health services?
I would say, from my experience, a good percentage. If they outcry, it all depends about when you outcry, right? Because there are people who don't outcry until they're adults about their abuse. That happens often too, right? But if a child makes an outcry young enough, there are networks of support services for them, right? So there are kind of layers to catch to make sure they get into therapy. So if they make an outcry of, I'm just going to say sexual abuse, because also sexual abuse is the most common form of abuse that was interviewed at the Child Advocacy Center. So I'm just going to use a sexual abuse example. When they go and get their forensic interview and are asked details of what happened, a lot of times there's a person there who talks to the caregiver and explains to them psychosocial stuff, the importance of therapy, things like that. Then when they end up working with me on the medical side, I'm also there kind of as another network of like, hey, caregiver, this is why therapy is important. Here are resources, things like that. And then if CPS is involved, that's another thing CPS will do, is make sure the kiddos get therapy. So that's another benefit of CPS, is they actually help parents find therapy. But it's challenging. I mean, here in Austin, there are long wait lists. Kiddos who have been victims of abuse have high mental health needs, high instances of suicidal ideation, self-harm. So there's never enough services. So I think that's the biggest challenge. But I do think, there are a lot of networks of people who try to make sure the caregivers understand the importance of getting their kid into therapy. Schools, I always tell parents, talk to the school counselor. They may have resources for therapy, or they may be able to provide a couple of sessions. So there are networks there and support systems, but it's just wait lists are really long. And, it all depends on what kind of abuse happened. But if there's a kid who has been a victim of continuous sexual abuse, I want to make sure they get with a therapist who is experienced in that and understands those dynamics, and what that looks like, what that might look like for a child, based on age and what kind of support they need.
Yeah. What would you say are some misconceptions people have about child abuse? and the way / process that this is responded to by both professionals and the state?
A couple things. Unfortunately, I think people don't realize how common it is. I think which I mean, I'm glad that people don't have to know all the stuff I know.
Yeah.
But it's way more common than you think. So this idea of kind of like, oh, it couldn't happen to this family I know, or it's not happening here. I mean, unfortunately, statistics show it does happen more. And there are risk factors, right? Families who have a lot of stress happening, right? Struggle with financial issues, families who are younger parent, there's all different red flags. Doesn't mean that they happen, in those homes, right. But there's things that are kind of, that
predisposed.
Yeah. Or an extra challenge or predisposition or, things like that. So it does happen more than you think it happens. That's my womp womp kind of statement. Kids are not just taken from their families. Right. I know that's a big one, and a lack of understanding of the CPS system, but there's a lot of people involved in cases. And my experience has only been in Austin. So I can't speak to what it's like in other states or other parts of Texas even. So I do also want to preface that I'm talking about my experience in the Austin County area, Austin, Travis County, Williamson County, things like that area. So I can't speak to other places.
Right.
But in my experience, and other people may have had different experiences, it's not just people take children for no reason. They're, I think the other thing too is that criminal investigations happen very slowly based on watching Law and Order, or, it seems like, oh, this gets wrapped up in one episode, but I'm always educating parents of in criminal investigations happen very slowly. They take months. Then the process of going to trial, if that happens, can take years. So I always talk to parents of, hey, what you can focus on is healing. What happens on the criminal side, a lot of times out of your control. But you focus on healing, getting into therapy, healing as a family, things like that. But detectives work on multiple cases at a time, and they need to gather the best information to have the best case possible. So it takes a while. So that's, I think, another misconception. I think thing too, that those of us who are in the field don't just assume things. Childhood accidents happen. Many of us have been parents or taken care of children. Falls, things totally happen. So we understand that it's not like your child has a bruise or breaks their leg or something, and people are gonna freak out and think it's child abuse. There are scientific ways to look at injuries and I'm mostly talking about to very young children. But people fall, people hold children and fall, kids fall, like all totally normal. And it's very much not just like, oh, kid has an injury, we're going to assume, it's some sort of abuse. I think that's a big misconception. Another thing too, I think spanking comes up a lot.
That's a good question I didn't ask about.
Yeah. So you are allowed to spank your child in the state of Texas. What you cannot do is cause an injury. So if you spank so hard that you leave a bruise, that would be concerning for child abuse. It goes against spanking goes against every medical body's recommendation of what is best for children. So when I talk about spanking, I say, listen, it's up to you. But there are other ways to engage in positive discipline, things like that. So my recommendation is always against spanking, but it becomes abuse when you're leaving injuries. We do see handprint marks a lot, or you're spanking with some sort of item, a cord or things like that.
Okay. Now, a big question recently, the Texas Senate passed a bill that would classify providing gender-affirming medical care to transgender minors as child abuse. Essentially, it would be made illegal for medical providers to provide things like puberty suppression medications, hormone replacement therapy, or perform any type of gender-affirming surgery or procedure. So, hypothetically, if this were to pass, how do you imagine facilities like the hospital you work at would address this if a minor patient presented at the facility and reported being on HRT, for example?
Yeah, so this law is complete and utter crap.
That's bullshit.
It's bullshit. I wasn't sure if I could curse, but it's bullshit. It also goes against every medical body's recommendation. So it goes against the AMA,
The World Professional Association for Transgender Health.
yeah, basically every medical body, the American APSAC, the American Professional Society for Abuse Against Children. So it goes against every medical recommendation. What I do know is that many children's hospitals are lobbying against the bill. So many hospitals have advocacy programs within there. And so there is a lot of advocacy happening. So I do not think this will fully pass because it would literally wreak havoc on the system. There would be I don't think anyone would be able to actually fully look into it. Would put an undue burden on child abuse systems on the CPS side, on the medical side, on the long-term
on the mental health side.
Mental health. I mean, everything. It would be a disaster. And most medical professionals agree and are, actively doing what they can to prevent this bill from happening. But it is, like I said, goes against every medical thing we know.
Well, I mean, I just think that the suicide rate, I mean, already the suicide rate for trans people is 41%. A 41% suicide attempt rate. That is absolutely ridiculous. And I think that putting legislation, passing a bill like this would just increase that.
It would have complete, and that's why medical bodies are against it, because it would have complete detrimental mental health effect on children, teens, caregivers. I mean, everyone. It would just be detrimental to families in every way. Absolutely.
If it did pass, what would that look like? Just kind of.
Honestly, I don't even know, because I don't even think I don't even know how they would put that into process. So honestly, I wish I could give you a better answer what that would look like, but I don't even think it's something that we've talked about, because we're just like, this is not gonna hard. But I don't know what that would look like I don't know how agencies, families would deal with that. I don't know what it would look like.
Yeah. It better not pass. That's all I've got to say about that.
Yeah.
Well, thank you for speaking about that, and thank you for saying what you said about it. Just not working.
Yeah, I mean, there's no medical, and I know this because I've talked with. This has come up on our team. We definitely, so when I say I don't even know what it would look like, I don't want to say this has come up and we have talked about it. And, like I said, every medical professional body that is of any kind of stature is against it and does not make any sort of medical sense, mental health sense in any way.
I mean, if you think about it, if say a kid did come in and they were on, say it was a trans male kiddo, if this kid was on HRT, well, then you'd have to file a report against the parent, a report against the medical provider. I mean, for supporting the child.
It would have an undue burden also on real cases. So that's another thing too, is it's really bad cases, right? If detectives, for example, are caught up having mandated to investigate that situation, they're going to have less time to investigate sexual abuse of a child by an uncle. You know what I'm saying? Like it would take away resources from actual trauma that is happening to kids.
And I think it's, although it may say be, potentially in the future against the law, that is not unethical conduct for a doctor. You know what I mean?
Mhm.
So, like, what would the criminal repercussions then be? I don't know. I'm just kind of thinking out loud here about what this would look like. Yeah.
It's just a disaster, and it is sad, because part of being anti-child abuse is being supportive of children, right, in their development and growth. And so this kind of situation goes against everything that I stand for, my team stands for, of supporting children in their mental health and their growth, helping children be the best they can be. So it just goes against all of that.
I appreciate you saying that. So let's hope on that.
Yes, absolutely.
And, another thing I'll mention is it goes against the gender affirmative model, that's been studied and is widely accepted as being the best approach toward gender in children specifically. Enough about my diatribe.
No. And you actually brought up a good point so a lot of times kids parents will come to me and who are uneducated about gender identity or things like that. And, after a child has been through trauma, they'll say something like, oh, my kiddo seems to be dressing more masculine, or, they'll bring that up. And I always say, all that is totally normal. It's, I understand what you're saying. There is no necessarily a link to having been through trauma and gender identity. It's all part of the normal growth process. So I always affirm all of that. And that also is evidence-based and all that kind of stuff.
Right. Okay. Well, switching to you more so now, and I'm sure I already know the answer to this question. What kind of experience do you have working with particularly vulnerable clients, such as those who are transgender, undocumented, or BIPOC, to name a few examples?
That comes up a lot because, like I started off saying, instances of child abuse are underreported in less vulnerable populations. And I don't want to say overreported in vulnerable populations, because I don't think overreported is the right word, because I don't think cases of child abuse get reported enough, but proportionally they are overreported than versus those of less vulnerable populations, if that makes sense.
Misused, maybe. It feels more along that lines.
So it's there should be an equal sort of reporting rate, and there's not, is what I'll say, because I don't like saying overreported, because that makes it sound like, oh, people then need to stop reporting concerns, and that's not it. But a lot of times, vulnerable populations, there are, and I also will say, in families that have a lot of undue stress on them, financial strain, disability, less access to services, right? That is going to create situations where child abuse can happen, right? If a family is not paid enough for good childcare, then they may be desperate for childcare, and they may have to leave their children and with someone they haven't been able to vet, right? They don't have options for childcare. Situations like that happen, that just sort of through the situation of being a underserved population, a vulnerable population comes up. So that does happen a lot. And so I do work with those populations often. Populations just speak different languages. And my goal is to give them the most aligned care as possible. I recently completed a certificate program on racism in the child welfare system program. So bodies like the American Professional Association for Child Abuse, we are working towards having training programs that focus on the IPOC, things like that, to give them the most supportive care possible, give them services that are lacking, things like that.
Okay.
Yeah. It's important to me that they receive care in their language that is affirming of their identity, all those types of things. So when I am helping them get connected to services, I want to find therapists who speak the language they speak, right? Have a collected background with them, things like that.
So, and I wonder too, going back to race, like, and I wonder if there's ways to track this sort of stuff within like the CPS system, like how many calls on like Black families are coming from white people, for example, and those sorts of things.
Yeah, I don't, and I'm curious to wonder if that stuff is tracked too. I don't know if it is, because the system, they try to make it as anonymous as possible. So like who makes a report, that information is not like released to like anyone, because a lot of times people don't make reports or fear of retaliation. That has actually come up quite a bit. But there may be ways they are tracking that. I just don't know of any. And if they're not, they should be.
Yeah, agreed.
And, training on reporting needs to be happening in schools of every socioeconomic status and every community, things like that. So sort of the bar should look exactly the same across all of those different lines. And it doesn't, and that is a problem. And it is something that institutions need to be examining and actively working against, and taking anti-racism into account in all of their trainings and all that kind of stuff, and be tracking those numbers so they can continue to evolve their practices to be actively anti-racist.
And, abuse is abuse, but I would imagine there's also certain cultural considerations to take in,
There's a famous case of that that we use when looking at that. There's a population that uses cupping as a form of healing. And so there was a famous situation, it was in like one of my textbooks, I believe it was in Minnesota, where there were all these situations of abuse reports of children because they had these circular bruises all across their back. And it, after kind of like an understanding what was happening, it was the cultural practice of cupping. So definitely there is things, and I know the team I work on, we try and take that into consideration as much as possible. That is a big thing that comes up with spanking, because spanking does happen in some cultures more than others. So it's really hard because and I always tell families when I talk to them about their practices, I say, you do what's comfortable and respectful for your family, but with your culture. And so I actually say that, but I will say things like, there is research about spanking, and here are some ways you could also try. I think a big cultural one comes up with spanking. It definitely comes up, but not as much as you think, because there's some pretty clear cut. If a baby who cannot walk has 12 broken ribs, so a lot of the cases, and then sexual abuse, I think are pretty clear cut. Perceptions on what we view as a child age in terms of sexual abuse, right? There are some cultures where at 13, 14, you're considered an adult or like a woman or a man. And so consenting to sex may not seem as big of a deal as it does to say to me. So there are issues that come up surrounding that that can be hard.
So say a child and their parent are at the hospital and there's some sort of child abuse suspected. What is your approach to this?
So there's a lot of different things that can happen, and it can depend on the age of the child and what the concern is. So I'm trying to use an example. Okay, so if a child comes in with, say they're 5 months old and they have a skull fracture, that happens a lot. That's awful. I'll say that again.
That's awful.
Yeah. But there's lots of accidental ways that can happen. people fall with babies all the time. It is totally normal. So yeah, skull fractures are actually a very common thing that come in because caregivers slip on toys or babies roll off the bed. That's a big one. Never put your baby on a bed unsupervised because you may not think they're rolling, but that's the first time they do a roll and then they roll off the bed. So all that can happen. And so there are protocols in hospitals where, okay, we have a baby who is under 2 and has this injury. They go on a pathway, a non-accidental trauma pathway, which means they may get a social worker involved to get a full history and to get a full detailed account of what happens. And they do a medical workup. So then they look for, are there other injuries, and they may get a full history in the medical workup. And the only injury is a skull fracture. And mom is saying she tripped on the stairs and her and baby fell. Well, that's totally fine. So CPS wouldn't be, called or anything like that. That is a normal household fall.
But a case where CPS might be called is if mom has like a seizure and is carrying baby, or if
but that's more not
mental
really,
health stuff.
That hasn't really come up. It's more so mom notices she's bathing baby and there's like a boggy spot on the head. And so she brings baby in and it turns out baby has a skull fracture and there's no history. Mom and dad say, I don't know how this happened. Well, if this baby's 5 months old, they didn't do this to themselves, or 3 months old. They didn't, there should be a history of what happened and the history should make sense. So, I'm sure the situation you brought up happens, but in my 4 or 5 years of doing this, it's more so that kind of thing where, okay, we have a baby with an injury that could not have happened to themselves without anyone knowing. We have a concern. Or, okay, mom says there was a fall, so we do our protocol and it turns out there's multiple fractures, right? That doesn't really make sense medically with the story. So it gets children get on a pathway of, okay, there's a concern. Doesn't mean we're going to call CPS. It just means we want to look at some more medical stuff to give us more data, and then if it's sexual abuse, that's a physical abuse kind of example. So if a child comes in with sexual abuse, there's a couple things that can happen. First off, if they make an outcry of sexual abuse, the social worker would make a law enforcement and CPS report. And a sexual assault forensic exam could happen if the assault happened within a certain hour time frame. And with different law enforcement jurisdictions, that time frame is different. The most would be 120 hours. So if a child makes an outcry of sexual abuse within 120 hours of that abuse happening, they will have a sexual assault forensic exam by a sexual assault nurse examiner. And in that exam, they're looking to see if there's any evidence. Very rarely there is, but they check. And they also do things like run for pregnancy, STIs, all kinds of stuff. If a child makes an outcry, and law enforcement has to approve those exams. So they say, okay, does it meet the qualifications for this, meaning it happened within the right time frame and they're outcrying to touching or something, some sort of skin to skin contact. If it happens within more than that time frame, meaning child makes an outcry that something happened 2 years ago, they will end up most likely getting a non-acute sexual abuse exam. And so my team gets involved where I work in the non-acute sexual abuse exams. And so that's really a comprehensive appointment they have where we do get psychosocial information, make sure the family has access to counseling, understanding what happened, screen kiddos for mental health concerns, and there usually is an exam done to see if there's any permanent injuries. There wouldn't be any, obvious evidence to collect, but just checking to make sure that the kiddo is healthy. And kiddos can do that or they cannot do that. It's totally up to them. The non-acute, everything is up to them. Everything in these processes are created to be trauma informed. Something bad happened to them and they did not have a say over their body, but all of these processes, they have a say over. They don't have to do anything they do not want to do. And that is like our number one guiding point. We tell kids that they're the boss. We tell them, here are these options. You can pick whatever combination of them you want. So all these processes are made to be as trauma informed as something like this could be.
Okay, I see. And what I was getting at earlier with the example about, like, say a mom having a seizure and falling with her baby is like, maybe the mom isn't taking care of herself. Maybe she's not taking the necessary medications. You know, that would, it was just more so to give an example of like another type of potential report that could be made.
Absolutely. Yeah. And so that would definitely, if that happens, they would probably get more information. Okay, mom, do you have medication? Okay, you are taking medication. So yeah, I think, but if mom says, oh, I have medication, but I don't take it, I think that could be concerning enough for me. And I would make a CPS report. Mom has, you know, something that may inhibit her ability to take care of a child. Not necessarily that it's going to go to this, removal, anything like that, but hey, this may need some resources to make sure they can afford medication, right? They may need to know where they can get medication from. So yeah, absolutely. If that situation came up, I would make a CPS report and feel confident that's the right thing to do.
Gotcha. Okay. How would you say your patients describe or experience you?
So a lot of what I do, I talk to caregivers a lot. So I work with kids and caregivers. And a lot of what I'm doing with caregivers is education. But I try to come from the most empathetic place I can. So when I talk to caregivers, they're the protective caregivers, meaning they're not anyone who's been a perpetrator of abuse. So they just went through something terrible too. These are caregivers who realize that their child has been physically, sexually abused by someone they probably know too. So they're through a trauma. So I come at it at that lens. I am not only educating them about their child, but about themselves, what they may be going through, making sure they have resources for therapy, just asking them how they're doing. You know, before I start off anything, I sit and ask them how they are. So I try to be as empathetic and gentle as possible, because sometimes we're doing this so long, you know, you're like, we know all the information and the data, but this is totally new to them and nothing they ever expected to happen. So I think I try to be as patient and empathetic as I can. Okay.
Do you laugh or cry with your patients?
Absolutely. Part of that is cry. I think cry has happened. And if I say that, I'll say, you know, I'll name it in the session and say, hey, you know, what you're saying is moving, you know, name it. But I think laughing happens a lot more because, you know, they'll make jokes and, you know, it's sort of that breaking that ice piece of it. So absolutely. Laughing is just a part of human nature and creating safe space. And so I think we definitely building rapport. That's the word I'm looking for. Laughing is part of building rapport and, you know, part of processing and all that kind of stuff.
How do you define holding space for someone?
I think it kind of what I talked about in that when the kid comes in, you know, they are seen as like the victim and all these services for them. But I make it a point to hold space for the caregiver by allowing them to have space to express what they're feeling. You know, a lot of parents, understandably so, are so caught up with getting their kid connected to therapy, they like haven't even thought of themselves at all. So I make it a point to bring up their emotions and their self-care. And I talk with them, what are some self-care things you can do and who are people you can talk to, you know? And talk about the benefits of therapy. I'm all about preaching the benefits of therapy. So, you know, and holding space for them is, I think, educating them that there's a place they can go, that space is held for them, if that makes sense. So and it's a bummer, you know, I don't always have as much time with caregivers as I would love. So I'm kind of using what I have to make it work. But building that rapport and giving them an opportunity to share and normalizing, I think, is a big one. Whatever they're feeling is normal. They may be sad, mad, frustrated at the child. They may want to still talk to, and this is the same for children too. All these things are normal. They may still want to talk to the perpetrator that did this to them. They may still love them. so normalizing all those things, because they may be embarrassed about these feelings.
Yeah. And I mean, you don't want to come in hard because then that person is just going to get defensive and shut down.
Oh, absolutely. And there's no right way to hear that someone you love abused your child,
Right.
or someone you cared about, or someone, so as long as they're being protective, that's fine. Any emotion they're feeling is a normal part of the healing process.
Mm-hmm. What's the best advice you've ever received from a supervisor?
I think what I named earlier of that metaphor, using that to help explain child abuse, hearing that was so helpful, because I get the question all the time, why wouldn't my kid have told me when it happened? Every time almost I work, especially victims of sexual abuse, their parents, or I don't understand, doesn't my kid feel safe with me? Like, why wouldn't they have said something? And that's what I use that analogy of, it's like jumping off a cliff, hoping there's a net. Kids don't outcry because they're scared. They're scared of retaliation. They're scared it may break up their family. They don't want to hurt the person they love. They know it's going to make their mom or dad sad, or, and so it was a supervisor who told me that analogy, and I was like, man, that is one I can use, because I think it's really impactful. And I think, and part of that is telling parents, it doesn't mean your child doesn't trust you. It doesn't mean they don't love you. It is normal for a child not to outcry right after it happened, because it's confusing.
Right. Yeah. What have you personally learned about yourself and or the world through your experiences as a social worker?
Humor is definitely healing. And when you're in a high trauma field, relationships are really important. I couldn't do what I do without my coworkers, who I'm able to talk to be in this with, right? To be in the trenches with of this, seeing this every day. Relationships are an important way to deal with what you're seeing. And so having strong coworkers you trust, by your side through all this, in any field, in any kind of, I think, social work field where you're seeing a lot of stuff, you need to have people who are working around you that you can process with, or use humor.
Be silly with. Yeah,
be silly with. Exactly. That is, there is no value you can put on how important that is, in dealing with all this.
Yeah, totally. So, given all the different types of things you see in a day, what do you do to take care of yourself?
Spending time with friends, being with my dog, knowing when it's becoming too much, and knowing which kind of cases are hard for me. It's hard to say, because now I think my answer would have been different 4 years ago. But I think it's a lot of spending time, having clear boundaries on my workday, not carrying work later. It's kind of funny working from home, because I was really strict about not taking work home with me. Now, we're all kind of working from home. So that's been kind of a new boundary that's had to kind of work with. But things like that, I think spending time with family and friends is the most important. Just spending time away from that world.
Yeah. Yeah. How would you define happiness?
I guess for me, happiness is comfort in a way, or comfort in what I'm doing, or taking pleasure from what I'm doing. It's hard to put a definition on happiness, but yeah, comfort and joy. Those are the things coming to me. It's not a perfect answer.
Comfort and joy. No, that's a good answer. Couple vulnerable questions. What is the most embarrassing moment you've had on the job?
Oh man, most embarrassing moment. I'm sure I've had many. I'm pretty good at being able to laugh them off. I'm sure I've walked in with food on my scrubs or something. I don't know. I'm kind of but I can't think of anything particularly embarrassing right now, but that not because it didn't happen. I'm sure I'm embarrassed myself all the time, but it's part of my personality. I feel like, so I'm good at just kind of laughing them off.
By the way, it must be nice to wear scrubs like at work.
Oh my gosh, I love wearing scrubs. It's basically just putting on pajamas and getting being able. When I started working at a hospital, I was like, I'm so into wearing scrubs. I love it.
Next, vulnerable question: are you in therapy, or have you ever been in therapy?
Yes, I am in therapy, and that was actually, I meant to add that as part of my self-care, or how I take care of myself after all this. Definitely therapy. Therapy, just to, and I think I talk about it less in therapy than I used to. But I absolutely believe that those of us who are holding space for others or holding space for other people's trauma, definitely need to have our own outlets. So yeah, I go to therapy. I recommend, very open about the fact that I go to therapy. My coworkers know I go to therapy. I recommend it, for any therapist. And so, yeah, I've been in therapy on and off for years. I think it's just like going to a doctor, right? I take care of my body by going to a doctor, and I take care of my mental health by seeing a therapist, and having space to process if there's a particularly hard case. But yeah, I don't know if it's just sort of time in the field, but it doesn't come up as much as it used to. But I think it's important to always have therapy there as an outlet if I do need to talk about something.
Agreed. Now, you mentioned right now you're currently in supervision to get your LCSW.
I am. So at my previous position, I was working on my LCSW. At my position I'm at now at the hospital, I have not started working on it again. So I'm not actively working on it. But I only have like less than half a year left to finish it. I kind of, when I switched positions, I was kind of made it a little funky, and then I was going to start it up again, and then the pandemic. I was in the process of looking at supervisors, and then the pandemic happened, and it just sort of changed everything, obviously. And so I am very close to getting my LCSW, so I do have plans to finish that.
Do you know what you want to do after that? Are you going to stay in the hospiol, or are you going to
My goal, I think, is to work with kids individually, to do work with high trauma kids on, long-term therapy. I love working with kids, no matter what they've gone through. Kids are fun and silly, and, you get to use really fun ways to process the world around them. Color, toys, sand tray, Play-Doh. I mean, you can use that stuff with adults too, and we should.
Sure.
But yeah, so in some capacity, I don't know exactly what, but I want to be working with children. And I think I'd love to work with them individually.
I was hoping that's what you would say, because we need more people doing that kind of work.
We do. There's not enough.
Not nearly enough.
There's never enough. There's always wait lists. There's always, and I think therapists who have an understanding of what it's like to be in the foster care system, or what it's like to just going through this process, or the dynamics of sexual abuse and all that kind of stuff. So yes, because I've been able to have these experiences, I definitely want to do private, some sort of practice and work with kiddos.
Awesome. Well, you keep me up to date about that. Well, Sydney, is there anything else that you think would be good for a potential client or other medical or mental health professionals to know about you and/or the topic of child abuse?
I think with child abuse, I know, especially in your professional world, it's scary, right? But there's sort of what I go by is if it's enough to have a concern, just make a report. Right. Also, to protect yourself. Mm-hmm. That's an important reason why, but it is a reason, right? You need to protect yourself. You are mandated by law. Leave it up to the professionals. That's what when I do trainings, because I also do trainings in the community. Let the professionals look at this, because there are maybe elements you don't know that they may know. And so don't put it on your head, your your shoulders to decide.
Your job is not to investigate.
Your job is not to investigate. It's not even my job to investigate. You know, I do not investigate cases. So I always, you know, they are the ones who are mandated to investigate. But if you have a suspicion, and if you're waffling between make a report, don't make a report, make a report. Keep that report number. They'll give you like a number, usually starts at 7. Keep that. You did your due diligence. And if there's some reason you're not sure, seek supervision about it. You know, talk to your peers or your supervisor. But I'm sure they would say just go ahead and make the report. And if it doesn't meet requirements, they will just close it, and nobody will know. If you have to make a report on a family you see, that family will not know that you made the report if they just close it. You know, so and you know. I've had to name in sessions that I made a report and stuff. And there's ways to name if you have to, for some reason, you have to name that you made a report, do it. But even if you get information where, you know, maybe mom says, oh, I just found out that my sister, I'm just making up a thing, but like has been doing drugs around her 1-year-old, you know, make a report on that too, because even if it's not your client, that safety of that kid is number one, you know? So, the other thing I think is really important, if a child makes an outcry of abuse to you, you may be the only person they made an outcry to. So if you do nothing, they're going to think, well, if I make an outcry, the adults just do nothing. Right. So you may be the one person out of all the adults in their life, they felt safe. So it is your job to protect them. And I'm going to go a little bit, I think, into like how to respond if a child makes an outcry. Don't ask them a lot of questions, and don't make promises. So sometimes what a kiddo would do is come to you and say, hey, I have something I want to tell you, but do you promise you won't tell anyone? Never make a promise. Always say, thank you for trusting me. I don't know what you're going to tell me, and my job is to make sure you and other kids are safe. So I may have to tell other people, but, it's because of safety. Always bring it back to safety. And a lot of times still will say, and don't ask them a ton of questions. Get enough information to make a report. So if they say, someone touched me inappropriately, get enough to understand, is this somebody in the home? But don't ask them a bunch of questions about it. Leave that up to the professionals. Right. And say, thank you for trusting me. I'm going to, do what I can to make sure you're safe. That kind of stuff. But don't ask them a lot of questions about it. Don't ask them dates. Don't ask them timeframes, like anything like that. Just get enough information you need to make the report. Okay, you're saying it's, what's the name of this person? Okay, that kind of thing.
Got it. Well, thank you so much for being on the show, Sydney. I'm really glad that families and kiddos have you as a resource and advocate.
Thanks. And if anyone I'm open to, if anyone has questions about anything I've said, I'm happy to chat about it, or any other things come up. It's a sticky topic. And so I want to help people make it as unsticky as possible.
Appreciate that. Thanks again.
All right. Thanks.
The next question.
Thank you for listening to Next Quest podcast. I learned something new today, and I hope you did too. Stay tuned for next week's episode featuring Samantha Meyer, LPC Associate, supervised by Natasha Justo, Licensed Professional Counselor Supervisor, who will be discussing her practice in an area of specialty, mental health accessibility, and mutual aid. Next Quest podcast is sponsored by Jan Dimmitt Resources. Save yourself the time and stress of credentialing and let the experts at Jan Dimmitt Resources do what they do best. For over 20 years, Jan Dimmitt Resources has provided administrative support and credentialing services to mental health professionals in Texas and beyond. Visit their website at jandimmitt.com. That is JANDIMMITT.com, or call 512-731-5725 for more information on all the ways they can make running your practice easier for you. NextQuest podcasts rely solely on donations to keep this project going. Please consider becoming a patron on my Patreon page at www.patreon, that's patreon.com/NextQuestPodcast, or you can make a one-time donation on my website at www.nextquestcounseling.com/about-NextQuestPodcast. You can also support the podcast by liking our Facebook page. Until next question, this is Noah Garcia signing off.